start the webinar. So we're still waiting for the numbers to go up. We're sitting at 220. We're expecting quite a number. Thank you, everybody. We're expecting quite a number of participants in tonight's webinar. And I just want to right off apologize if I will get any connectivity problems. I've tried to ensure that I have stable connectivity, but I'm getting a message that there might be issues and that the panelists might not be seeing my video. Can you see me now? I'm taking that now you can see me. I am not hanging anymore because I was also hanging. Thank you. The numbers are still rising at 260, but they seem to be stabilizing now. So maybe without further ado, let us start the webinar. Tonight's webinar is being hosted by APSA, and we have Dr. Haffajee as the presenter. Just a few housekeeping rules. Please, participants, refrain from using the raised hand. Type your comments and questions in the Q&A and not in the chat. So also be aware that, as usual, CPD certificates will be loaded onto the SADA platform, and you'll be able to access all your certificates under your member profile. And if you're not a SADA member, you will be able to create a profile for yourself and to access your CPD certificate. The event tonight qualifies for 1 clinical CEU, and we are also streaming live on the SADA YouTube channel. So just in case you're not, any of our colleagues are not able to log on to the Zoom meeting, they can still access the webinar via the YouTube channel. So at the end of the webinar, please don't forget to complete the survey. SADA really appreciates the feedback that participants give for each of these webinars. And just to announce the upcoming webinars, on Thursday we have a Henry Schein evening with international speaker Dr. Tara Hanon. And next Tuesday we have Saspia, who will be hosting, and we'll have Dr. Fahim Bamji. And next Thursday, it will be another Henry Schein evening with international speaker, Dr. James Robson. So remember to type your questions in the Q&A and not the chat box. And don't use the raised hand, please. Even complimentary comments on the Q&A platform are appreciated. Without further ado, I will also introduce Dr. Osman Lateeb to introduce the speaker. Over to you, Dr. Osman Lateeb.
Thank you, Professor Moipolai. Good evening, colleagues. Today, I would like to introduce you to a young dentist who is formerly from Durban, and he graduated at the University of the Western Cape in 2011 and went on to complete his community service at the South African Military Health Services in Mtubatuba, KwaZulu-Natal. His journey to prosthodontics began with him moving back to Cape Town to start with his Part 1 examination, as well as a postgraduate diploma in implantology through UWC. He began his registrarship training in prosthodontics in 2015 and wrote his final exams in 2019. He is currently completing his thesis and is in private practice close to advanced restorative dentistry in Century City. He is involved in various programs, including the International Team for Implantology, South African Academy of Aesthetics Dentistry, as well as the Islamic Medical Association. On that note, I would like to hand you over to Dr. Ridhwaan Haffajee, who is going to take us through entering 2021 with 2020 vision. Thank you, Dr. Haffajee.
Thanks, Dr. Latif. Thanks to everyone. Thanks everyone for signing in this evening. It's certainly a pleasure to be able to speak on this platform, and also a little bit intimidating to the number of delegates that have signed in. But needless to say, I think most of us have got used to speaking to a screen or paying attention to a screen. The topic for this evening, entering 2021 with 2020 vision. And the reason why I chose this topic, and I think probably this audience becomes the most intimidating audience to speak to, because I think after going through COVID and lockdown and so on and so forth, it's probably the most informed audience that we'll have for many generations to come. I think it's given us time to sit back, reflect, look at many aspects of practice, and I think people are coming out of this empowered. So I think beyond the so-called doom and gloom and the negativity that occurred and so on and so forth, I think a lot of positive has come out of it after looking at what we've gone through. Needless to say, I think in terms of the scope of this presentation, it's primarily going to be based around digital dentistry, more commonly known as CAD/CAM dentistry. And I think specifically, I'm not only going to touch on just the clinical aspects of it, but rather the all-encompassing components of digitizing one's practice. And I think there's a lot of publications out there looking at the positives of digitization, and it's obviously undoubted, the potentials and the possibilities. However, I think the more critical aspect of it is, and I'll be the first one to admit, that sometimes we overlook the risks and the ethical challenges because they're really discussed. I think when Dr. Latif was introducing me, I was like just thinking back to undergrad, and I think when you're an undergrad, there's always a different ego that gets everyone going to get through the next year or the next semester. And I think going into private practice now, I think it's safe to say that the current ego of dentistry it's really based on digital dentistry, whether it's a scanner or the CBCT, basically a new toy or a new gadget. And I think without sounding too cliche about it, with great power comes great responsibility. And with that responsibility comes accountability as well. And I think that's where we step in. And I look at this photo and I think it's really kind of sums up where digital dentistry is for me. This photo was taken with two good friends of mine, two colleagues, Fahim and Imran, when we just got the keys to where our current practice is. And I think we started practicing in February of this year, and we had no clue what was going to lay beyond the first day. And I think that's not looking at life with 2020 vision. So I think there's only so much of planning that we can do, but we need to try and assess blind spots as far as possible. And the other part of opening a practice, and I think for any restorative clinician, it's getting the Pentamix machine. I think anyone that's opening a new practice, whether they verbalize it or not, the Pentamix machine becomes that go-to toy, that device that we want to have. And I think it was that, it was that up until intraoral scanners came along. Needless to say, I think I'm fortunate enough to have access to both the Pentamix and intraoral scanners. And I look at things, well, I try to be as all-encompassing as needed. And one of these posts I put up on Instagram, and beyond all the likes and the comments and all of that there, the one comment that I got was, why plaster? And yeah, I think I'll be the first to admit it probably did scratch the ego a little bit, because I thought to myself, I don't know, it's planning. It's what we do. We take impressions, we have models, and we plan, and that's how we part of executing a treatment plan. And with this case, I did have an intraoral scan as well, and I thought maybe I was doing too much. Was I doing too much, or was I short of something in my digital planning that I should not have needed to take models? Needless to say, I think I took it on the chin, and I didn't feel too bad about it, because there certainly is a place and there's certainly a need for plaster. But I think at the same time, there's a lot of good clinicians out there that perhaps don't have access to intraoral scanners, and I don't think that makes them any less of a clinician. I think in the right situation, intraoral scanners work really well, and I think sometimes with a bit of ignorance, they can cause some disastrous effects. But I think in essence, when we're looking at the major areas of digital dentistry, we're looking at practice management, patient education, keeping records, and radiographs as well, both 2D and 3D. I didn't qualify too long ago, but I still remember using Developer and Fixer on my 2D radiographs. And I think now it's all digital, obviously. Then there's the intraoral imaging, as I touched on, and then our laboratories, CAD/CAM, in whatever means it may be, whether it's from the printing or the milling, but in essence, some sort of digitization should be occurring there. And then obviously lasers are the next big thing as well. I think if we had to look at an all-encompassing, fully classical digital practice, whether it's possible or not, especially in our context, it would look something like this. In terms of the top left-hand side, looking at the patient check-in, going through to consultation, and part of that consultation would include your records and the imaging, and then scanning as well as part of the records, and then your 3D planning, and then treatment execution. That's the ideal. Is it the goal? I think it is. But yeah, that's in essence how it should be. And I think in the short time that I've been in practice, it's safe for me to say that it's not always attainable. I think if I speak to my colleagues, just starting at patient check-in, just to have a purely efficient digital workflow from administration point of view, which includes your accounts and things like that there, is a mission. And there's a lot of snags, and I think every practice has its own permutations, and that's what makes it so much more difficult. But I think let's just go back in terms of looking at the clinical aspect of digital workflow. The traditional technique, taking a good impression, having a cast poured up, having a model poured up in gypsum, and then the fabrication of a prosthesis in the lost wax technique versus computerized engineering technology, or CAD/CAM. And which one are we going for? Which one is better? Which one is the gold standard? I think the term gold standard is going to come up a couple of times in this presentation, and I think at the end of this, I still don't know which is the gold standard, and I don't think there will be. I think it's good to say that we don't have, or we won't always have, a gold standard, because it means that we're obviously improving. However, digital dentistry has obviously opened up a whole world of opportunities for us in here. I think fixed prosthodontics, but I think removable prosthodontics is an aspect that does need to be looked into a little bit more, because there's certainly a place in that domain. And I think the ultimate reason for this is that more often than not, we can get consistent precision and it's reproducible production without the need of impressions and models and the issues that they come with. I think the fundamental goal that will always remain, that it's restoration driven or prosthodontic driven or restorative driven, regardless of how vast your multidisciplinary team is, or if you are the clinician that is executing all of it. I think everything, the old cliche that top down. But the problem comes in when we're looking at evidence. I think everything we do needs to be based on evidence, and because technology is evolving so quickly, as the evidence comes in, we're already on to the next big thing, or the so-called next big thing. So we're always going to be a few steps behind in terms of the purest evidence and the evolving industry. And that goes to my next point, that unfortunately, fortunately, it is manufacturer driven, it is industry driven, and I think that's just the nature of the game. And I think that's where the responsibility comes from our side as being respecting clinicians to understand that not everything that is sold to you is actually good. I think just to touch, I think another part about this audience that it's so vast, and not all of us are going to have access or have used intraoral scanner, but we still have been doing some sort of dentistry that's partly digital. And in simple terms, from your dental office, your patient record could end up at a laboratory via either an intraoral scan, a digital file, or which would go in the format of an STL, or a conventional polyether type of impression or PVS impression. And the laboratory would either be able to digitize the impression or pull up a model and digitize the model. And that's where your CAD/CAM process will actually so-called kick in. The two examples here, dry milling and wet milling. I'm not going to go into the details of restorative dentistry or surgery or the laboratory aspects of digital dentistry. I don't think that's the purpose of this lecture. I think I'm going to keep more to just keep it quite broad. So I'm not going to go into dry and wet milling. However, the changes are growing in this field and we need to accept it. Impression taking procedures, which were more and more replaced by intraoral scanning, as well as CAD/CAM production of anatomically full contour restorations, more often known as monolithic, or if you're going with a CAD/CAM type of restoration that's been veneered. And I think we do end up working in the space that is more mixed between analog and digital. And there's nothing wrong with that either. And combining both techniques does still end up with a very, very good end result. I think both have their benefits. And I think specifically, if you're just looking into a bit of the monolithic component, that in itself, I think most of us who've done some sort of monolithic work versus the veneering work do see the obvious advantages in more aesthetically challenging cases. However, before we go and say, let's kick out the old, we need the scientific validation. And whether that time will come, before this lecture, I was like thinking, whether or when will that time come that we'll ever kick out complete analog? I'm not sure. I don't think so. I think, especially looking at socio-economic groups, I think it'll be impossible to say we can kick out analog completely just based on that. But in essence, if any technique is being introduced into your practice, it needs to be based on the fundamentals of feasibility, biological outcomes, economic analysis of the entire workflow before it can be seen as something that's going to be introduced. From an introspective perspective, we need to look at what benefits do complete digital treatment concepts offer in the production of fixed dental prosthesis, and what quality level are they given compared to the so-called gold standard or the conventional pathway. And the second pathway, when you think about it, is what are the economic outcomes in a fully digitized workflow? And when I say fully digitized, there's certain individuals that are probably doing chairside milling. So basically scanning and designing and milling, or the individuals who would be sending it off to laboratory. And I think the argument obviously always comes in that you're doing chairside milling, you're either giving the patient a reduction in cost or you are billing the laboratory fee and pocketing it that yourself. In essence, there's a time component that goes with that, which does come with a cost component as well. And I think that needs to be quite transparent when this introspection does go through. Needless to say, one of the systematic reviews that I went through, it's a 2017 article, and I think systematic reviews are one of those 50-50s that we can't always hold too tightly, but there is value in them. But I think the end result from all the information that came through was that it really doesn't replace analog. And a lot of future trials are required, clinical trials specifically. A lot of the studies are laboratory based, and I think clinical studies are needed before we start saying digital is the new gold standard. But beyond it all, or beyond the whole fanfare of it, and beyond Facebook, Instagram, and that whole marketing thing, or telling your fellow dentists in the area that you got a scanner, what is the need for digital? Why was digital actually put out there? And I think if I had to narrow everything down, it basically goes down to passivity and accuracy. Passivity, it's a term that's generally, as I said, related to implant-borne structures, but in essence, it's where there's an absolute zero strain on the supporting structures of the prosthesis. So in essence, it just clicks in and it pulls out with any sort of resistance. And this passivity, or this concept of passivity, it's dependent on several factors. The accuracy of the impression technique, and the resultant master cast. And a failure to achieve passivity can lead to biological and mechanical complications. These complications are seen a lot more severely in implant prosthodontics. I think teeth are generally more forgiving. I'm not saying that it's okay to not have a passive fit, but the periodontal ligament generally does cover up a lot of our misfits, but implants are not forgiving at all, obviously. And that's where these complications do become quite exponential in nature. And in essence, we need to have a procedure that is reproducible. It doesn't make sense to have a procedure or a technique that works really well for one patient, but for every other patient, we kind of lost at sea. The other concept that's quite important in digital dentistry is accuracy. And this is broken down into two parts, precision and trueness. Precision basically represents the degree of reproducibility between the repeated measurements. As precision increases, the predictability of the measurement increases. And trueness, it basically describes the closeness of the actual dimensions of the object, which is defined by a comparison between the measurement control and the test object. So in essence, how are we able to recreate in a lifelike form or in a tangible form the intraoral situation on a platform that we can manufacture something? I think just for us to think about, for those who are probably still either against digital dentistry or feel that they don't need to get onto it, if you're looking at the speed of adaptation, and looking at back in 1876 when the telephone came in, before it reached 50 million users, it took 75 years. Came in the radio in 1912. It reached 50 million users in 38 years. Looking at the television, it reached 50 million users in 13 years. The World Wide Web took 4 years. The iPod took 3 years before it reached 50 million users. And Angry Birds, 35 days. So humans are adapting, our lifestyles are adapting to technology quite rapidly. And at the same time, we need to also remember that our practices have to also adapt. Not completely, not entirely, but there's a reason why technology has come in. It makes our life easier. It does create a more efficient type of process, and it's part of evolution. I think just to, before I come across as sounding a little bit anti-digital or for digital, in terms of workflows, same patient, the left image was before and the right was after. And this happened in 24 hours. Patient had a failed bridge. We couldn't take an impression of that. The bridge would have come out. Patient would have been in a whole lot of other issues, and an intraoral scanner with good CBCT and decent digital planning in a 24-hour outcome, we're able to achieve a decent result. Basically immediate loading of full arch prosthesis almost on the same day. That's where digital can take us. Does it work like this all the time? No, it doesn't. We have issues. I think it's easy for people to take on platforms or podiums to speak and show the ideal. I think it gives everybody this wow type of effect. But the reality is when you're in surgery and you're placing implants and the bone quality isn't what the CBCT said it was, the human element or the surgical skill is required, or an understanding of the surgical principles. I think getting more towards the presentation itself and looking at the ethical challenges and the implications. And one of those classical lines that our reps will always try to sell us or try to make us aware of is that you will get return on your investment in terms of a smoother and more flexible workflow, reduce cost and time, improved accuracy and a high level of predictability, the digital area is simply here to stay. So I suggest you jump on the bandwagon. And perhaps there is merit in what they're saying, but should we jump onto that bandwagon blindly? I think not. And I think there's parts that you, while putting together this presentation, it allowed me time to think about the way I approach digital dentistry and ways that I could improve or modify my outlook to it. So there's 8 challenges that I came across in the literature. The first challenge is big data, data security, data manipulation. I think this is a big thing. It came in with patient records not too long ago. How do we store records? And especially if it's going to be kept in an electronic or a digital format. And in essence, we need to preserve the patient's self-determination regarding their information. They have a legal right to access his or her data and decide on its use as well. And I think sometimes we almost detach ourselves from the patient because of digital dentistry, that sending around a patient's scan, CBCT, any sort of records is actually the patient's property. And if it's being sent for any purpose other than the patient's benefit and without the patient's consent, we obviously breaking some laws there. And the more data that we have, the more complex the situation and the greater the corresponding responsibility of the dental practitioner. And the same applies to the data that's being used for purposes other than the intended or what the patient intended. And here we're talking about commercial use, educational use, marketing, lectures. I think basically informed consent, and to what extent. It's fine to take photos of a patient, but are you going to be using it for marketing? I know SADA has something that came out recently on that, and I think that's a whole different discussion. But these things are warranted and valid areas of concern. Cloud-based storage and privacy guidelines. I think each country has their own, and I think in terms of safeguarding and protecting that, it also doesn't work true to have something saved in the cloud that has, and people that should not have access to patient information do have access to it. It's important. But in essence, with this big data, you get 2 phenomena. You get the so-called digital double and falsification. It took me a bit of time to understand digital double, but in essence, think discovery vitality. Maybe not specifically in the terms of our dental context, but network data. In the generation we live in, we can access or record via apps or inputting apps, health data, your movement, your living conditions, dietary conditions, social habits. I think Discovery and Shore even can measure your driving conditions, whether using your phone. And in essence, we've created a digital double of ourselves. And this also becomes a big responsibility as well, seeing that now from a clinical perspective, we are the custodians of this digital double. And the second component of it is falsification. Digital data is more easily falsified than analog, obviously, because I think if you can hack into any computer system to falsify data becomes easy, very easy. And that's not just imaging. We're looking at radiographic records, patient files, and so on and so forth. Obviously, there are ways of checking last edited or when the file was modified, but I think the falsification concept becomes a big thing as well. I found this quite alarming. Detecting the manipulation of digital clinical records in the dental practice. And dental X-ray images may be subject to manipulation with malicious intent using easily accessible computer software. In 2017, Dyers and their group basically sought to evaluate a dental practitioner's ability to identify a manipulated dental radiograph compared with the original. And the results were alarming. The participating dental practitioners were correct in identifying the manipulated image in 56% of the cases. And if you're looking at finding things by chance, it's that old thing of 50-50 chance. That means with the clinical background and a professional qualification, we're only able to pick up 6% more than just being it by chance. And this is concerning, and it's concerning on many regards, because we're not looking at falsifying your own radiographs, but if a medical legal type of situation had to occur, and either one of us were on the other end of it, and we had to either testify to a radiograph or write a report. What report do we give, and how accurate is that if things are being able? I think now here we're talking about radiographs, but Photoshop is there as well, and patient clinical images can easily be doctored. Challenge number 2, and I think this component does need a bit more work, and I think it's also largely based on the personality of the clinician as well. For the simple reason, you get certain clinicians that really want an intimate type of relationship with their patients, where they really get to know their patients, understand the patients, play a very, very close role in the treatment execution of the patients. And these others that are a bit more detached. Digital obviously changes that relationship a lot. And the role of the dental practitioner, especially under digitization, because that traditional two-way type of relationship has become a bit more indirect. Personally, for me, I like having a good relationship with my patients. I think from a prosthodontic perspective, treatment can stem a long time, can be quite extensive, financially, emotionally, physically taxing as well to patients. And it's important that we build good relationships with these patients, because and one of the things that you start seeing when you get into implantology is that patients will stay with you for life, and it's a responsibility to be able to manage those patients for life. So we, even in this digital domain or digital era, we still need to somehow keep that two-way relationship going all the time. I think the other part is, from my perspective, if I was looking at it from a digital perspective, again, intraoral scanning, photos and things really help with communication. If I think about when I first practiced in private practice, and that was in 2012, 2013, digital dentistry wasn't such a big thing. And I think speaking to patients, motivating treatment plans, educating patients on the oral health without the access of colored digital intraoral scanners, it was a lot more difficult. So now, if you are that type of clinician that likes to have a proper build a proper relationship with your patients, the digital area actually helps to reinstill that or motivate that. The one big benefit also, it becomes reduced chair time. The problem here becomes that you almost have an expert system type of dependence. So digitization in the wrong hands and becoming too dependent on the system can become a problem, because no system is an expert. The system basically works on a set of algorithms that's going to churn out whatever it thinks it needs for a patient. So I think it's important that there's definitely going to be input from a clinical perspective. And I think this is where that balance between an experienced clinician and a novice, and how digital marries into that. Because a novice clinician doesn't become better with digital. I think his shortcomings probably get covered up better. And at the same time, he or she puts himself out for a lot more catastrophic failures by being ignorant about it. So I think it's really important to continuously be self-empowered or be educated on this. Another challenge in introducing digital dentistry into a practice is digital literacy. And I think we're looking at not just dentists that are qualified in the last 5 or 10 years, we're looking at clinicians that would probably be in their 50s, 60s, and sometimes in the 70s. And there's going to be a so-called literal type of aspect to that, because now it's no longer taking and mixing alginate or using Improgam. It's really trying to wrap your head around a system that's very different. And I think you can always break that group of individuals down into your early adopters, the late adopters, and the non-adopters. I don't think there's anything wrong with being a late adopter. The only problem with being a late adopter is that by the time you do adopt, the next thing is going to be out and your technology is probably going to be too old. Definitely have a problem with being a non-adopter. And the early adopters, so-called pioneers, I think those are the risk takers. In calculated situations, we need them. They lay the foundations for future evidence, research, feedback, improvements. This is a big thing. And I think especially from a prosthodontic perspective and when you start treating patients on a specialized or more advanced level, this part becomes a bit of a touchy subject, assuming responsibility when using technical systems, and who takes the responsibility. Because as long as the system works smoothly and without errors, there's no reason for complaint. But when the complications do arise, who's wrong? Who takes the blame for it? Because in essence, the individual is the clinician that actually advised the treatment, well, firstly diagnosed, advised the treatment plan, executed the treatment plan, and a complication arose. And I think from a moral standpoint, if a piece of hardware was delivered and it came from the factory and there was something wrong with it and the clinician wasn't aware of it and he used it and then complications arose, yes, there's a second and a third and possibly a fourth party. Laboratory technicians, if a file was corrupted in the process. These things will happen when you're dealing with technology. We have to accept that. But I think the concept of diffusion of responsibility is something that we need to be very, very much aware of. For the simple reason, I think fundamentally, we are healthcare practitioners and our primary mandate is to help patients and do no harm. And whatever we do, we need to be able to own it. And again, it's risk versus benefit. And if we know that there's going to be a risk or a blind spot that we can't work around, then we perhaps should not be using that type of procedure. And I think also as soon as we are aware of something, we need to stop. And I think the last thing based on this is the learning curve. We need to accept that there is a learning curve and it doesn't make sense to be starting a full mouth rehabilitation or starting digital dentistry or using an intraoral scanner on your first full mouth case. I think it should start with a single crown posterior and then work your way forward as you get familiar with the system. The other thing, I think also starting a practice new, I probably came across this, and changes in the professional profile and self-image of dental practitioners and the dental technicians. I think two ways. Firstly, the way I look at the laboratories that I work with, if there's any technicians sitting in, they're probably going to have a little chuckle about it, but it's very often that you're working with a technician and you basically ask them, what's your access to CAD/CAM? Do you have a milling machine? Do you have a printing setup? What CAD/CAM software do you have? And the whole thing. And you end up, at times, you meet certain laboratories that are fully kitted out, and there's other laboratories that end up giving an answer of, we have access to it, or they don't have it on site, but they send the models away to get scanned and someone designs and mills and so on and so forth. And I think the way we start choosing from a clinical perspective, the way we start choosing our laboratories can sometimes lead to that bias there, that we could end up tending more towards a laboratory that has all the toys, gizmos, and gadgets, but at times, perhaps maybe doesn't have the know-how of a purely analog laboratory setup that outsources the digital work. And I think we also need to be aware of not getting carried away in that same hysteria and euphoria of digital dentistry. And I think from a patient perspective, I probably was caught up stump, I'll be the first to admit. You get patients that will come in and they need a crown, and the patient will ask, would you be able to make the crown the same day for me? They probably perhaps went to another clinician, either had an opinion before me, or they perhaps had a crown made the same day. And I don't have an in-house milling system, and the way the patients will perceive it to be is that that is the new gold standard. That is what a dental practitioner should have. I'm not saying this is a bad challenge. It's something that I also take with some sort of positivity, that as a dental profession, we do need to encourage growth, improvement, and we do need to be challenged in this way. I think we can easily go by 30 years in practice and not have anything as simple as a Pentamix machine. And I think it's important that after a certain number of years, and I think we shouldn't be investing in this type of technology immediately. And there's obviously finances with it, but I think growth and development and over time goals need to be set. I think it's important to take pride in the work that we do, and our image or the image of the work that we put out needs to show that. The cost trap. An intraoral scanner starts up on what, 250,000 Rand and goes up to 650,000 Rand. A a full digital setup can cost close to 1.5 million rand. It's a lot of money. It's an exorbitant sum of money sometimes if you think about it, considering that we still need to live a life outside of a dental practice. And we can very easily fall into this amortization trap. Basically the action of or process of gradually writing off the initial cost of an asset. So in essence, we fall into this trap of trying to sell treatment more than what we should or what we need to, just based on the fact that we need to pay off our equipment. And it's this vicious cycle that we get in, because all of us know that when we start selling treatment or we start doing too much work, then we end up in trouble, because patients will start realizing, patients start getting that. I think patients are really intuitive. It's one thing I probably learned, that patients pick up a lot, and they will start seeing these things, that the guy's probably trying to sell me more than what he needs to. Puts your practice in a bad credibility. And I think sometimes also, if the ethical part, that goes without saying, but I think it should be said, doing more than what you should be is a problem. And you're putting your patient at risk for unnecessary type of complications long term. And I think we can sometimes, I think everybody can find a way of justifying doing a certain type of procedure, but there's always the little voice that will whisper in the back of your head and tell you, look, maybe that tooth didn't need to be a crown. Maybe a straight two-surface composite, MO, would have been fine. It doesn't mean that because a tooth has a crown, it needs, or because a tooth has a restoration, it needs a crown, because you have a milling facility. Yeah, I think the other part of it is where we start motivating this over-treatment from a forensic perspective. You have a CBCT, it costs you 900,000 Rand, and you need to make money on it. So you start taking CBCTs for patients empirically. Patient comes in, part of your general workup is take a CBCT. That is a problem. Obviously, there's always going to be the debate of exposure and how little certain CBCTs are compared to PANs and so on and so forth. But with that being said, there comes a responsibility of reporting on a CBCT. A full mouth CBCT or 8x11 is going to show quite a bit of anatomy, and it's important that the individual that has taken that CBCT does due respect or diligence to that process. And then I think the other part that we think about is managing incidental findings. A simple example is patient will come in with pain in the first quadrant, but you pick up what looks like a periapical lesion in the third quadrant. Do you treat that? Do you make the patient aware of that? What's the diagnostic criteria for that? Does every black spot, dark spot mean that we need to get in there and do surgery or redo a root canal? I think, and we need to, I think the most important thing is, from a personal perspective, what I think works is, before the investment is actually made for whatever technology we're going for, is to think back and say, what is the purpose of this? What do I want to achieve out of it? And work on from there. So 6 months, a year down the line, when you have a machine that's not making the money you thought it's going to make, you're able to reel yourself back in and just talk to yourself and say, look, this was not the purpose of it. Challenge number 7, bit of a gray one, but basically the consumption spiral or the ecological footprint of medical or dental technology. And if we're looking at things in terms of, from a practical sense, it shows that the constant increase in efficiency potentials leads to ever more new devices, further developments of existing systems, or regular updates. I think anyone that's been in practice for many years, uncle of mine has a private practice in Durban, and he's been in practice for close to 25, 30 years. And I think anybody who's been in practice that long will probably bear testimony to this, that you probably have a storeroom of devices, toys that had just been sitting and laying around, and you probably used it 6 months, a year, and the next thing came about and you end up getting the new one. And it was always justified by some sort of deal or combo package that the rep sold you, but in essence, there's an ecological footprint to that. What are we doing with it? Are we disposing of it? And I think it's quite apt that we're talking about it, especially in 2020, because right now ecological footprint is quite high with gloves and masks and disposable gowns that we've been chucking around. But I think in the same way that although many hopes are pinned on digitization, and the sustainability aspect is really taken into account, especially in the case of innovations. if I think about when I was an undergraduate, I think the Sirona Blue Cam was out at that time, and that was the amazing thing. And by the time I became a registrar, the Omnicam was out, and no one even looked at the Blue Cam. I think it just laid in the corner, and it just became something that collected dust. And Prime Scan is out now, and it's a fantastic bit of technology. But what happens to Omnicam? And I think this will continue forever on end, but in certain aspects, it's important that we do take that jump and do invest in new technology, but investing wisely into it. So I think in simple terms, that extremely high pace of innovation cycle that involves the release of more and more devices and infrastructures with the corresponding disposable requirements. And this also applies to the increasing technological healthcare system, and thus to dentistry as well. Challenge 8, and I say clinical evidence or the lack of it. And the market launch and the success of new digital technology is often independent of scientific evidence. And I think that's just how it goes with most things. Things get released and then we say, let's test it. And as much as we try to narrow that gap between our independent academics and industry, there's always going to be that situation. And I think perhaps because of evolving technology, academics probably need to speed up a little bit more, but there's only so fast that things can happen. And yeah, I think that's pretty much self-explanatory eventually, that things evolve so quickly and we need to be able to keep up, but still using sound clinical evidence. So I think enough talking, and I'm going to go through about 3 cases, and which I felt were quite apt in terms of looking at digitization and what can go wrong and what can go right with it. And the first patient is a patient that presented to the practice, and I think I've only been in practice a few months, and I've seen the good, you see the bad, and I think the bad makes you aware of how much on guard I should be in terms of the work that we execute, because I think more than, I think we always say the patients move around and patients will be seen by someone else. I think that's absolute nonsense. We shouldn't be trying to be good clinicians because patients are going to move around. We should be good clinicians because we're actually executing treatment plans on patients that are living objects, are people with personalities and feelings and emotions. And this patient is a young girl. She's 27 years old, and she's a model of some sort. And she was at a practice abroad, and she was sold, I don't want to say a digital smile design, but she was basically sold a same day type of veneer with some sort of aesthetic smile design type of situation. And the way she described it, she walked into the practice, there were images, photos, records taken, and treatment plan was given to her. It was going to be 8 veneers, 10 veneers, and the next thing she knew, the next day it was for prep and mill the same day, and it went in. And ever since then, she's been having severe pain. And I think it's quite obvious to see that there was a violation of biological width, quite severely. And we obviously didn't have access to pre-operative records, but I think fundamentally, there's soft tissue inflammation that was not there before, and it's a problem. So yes, digital technology has its place and it works and it's predictable, but in the wrong hands can be quite catastrophic. The other thing that I picked up quite aptly while trying to remove these veneers as part of the diagnostic process was the depth of material. And yes, if I'm looking at the lateral incisor that's just broken off on the right hand side, perhaps it was prepless, perhaps it was minimally prepped, but in essence, there was a restoration that was overly contoured. A really thick chunk of ceramic was there, and that was removed. Needless to say, the irony is we went back to digital technology to try and correct and assist her in this process. So yes, it was intraoral scans and as well as CBCT, bone sounding, so on and so forth, to try and recreate a healthy biological interface. Another one, I think this one actually was one of the cases that really got me thinking about the challenges that I mentioned earlier, clear aligner therapy. And it seems easy. From the little that I know, it's basically you take an impression, you take a scan, and you get a proposal and your problems are solved. And this case came along and the referral was for an implant at 2.2. And the patient had been on aligner therapy for between 12 and 18 months. And the patient was obviously excited. He was excited that she had invested all of this time into aligner therapy and she was now going to be getting her implant. And she was going to replace the removable denture that she's had all her life, and she saved up enough money to get her implant done. And it's quite obvious to see that there's a space issue. One of the issues, obviously, but the first thing was a space issue. And when we're looking at this patient, and this is not looking at, there's a reason why I haven't shown a CIF, haven't shown profile images, haven't shown a smile, because aligner therapy doesn't take those. The way it's executed in daily practice, yes, sure enough, there are individuals that do execute aligner therapy the correct way and using principles that they've been taught, but it's promoted in a very simplistic way. Take an impression and it's sold. It's market driven as well. There's no space. And if we look at the occlusal surface, so the implant was required at 2.2, but there's a missing 2.6. And the first question that I asked the patient was, what happens to the carious lesions? So again, technology was proposed to the patient, it was executed to the patient, but fundamentals of a leaking restoration on the 1.7 and caries on the 2.7 were not adhered to. And I think now this starts falling into the domain of negligence. Yes, it's not going to be a malpractice suit, but it's something that is concerning because without adhering to baselines, there's things that are gone wrong. And obviously, everyone knows prosthodontists, prosthodontics, occlusion. We like occlusion. That's all people think that we studied for 4 years. But the reality is here, there is no occlusion, or there's no, I think, looking at conformative, reorganized or unorganized, those three big principles, and this is definitely one of those unorganized cases. And aligner therapy was executed without any diligence or any adherence to the fundamentals of occlusion. And why is it important? I think it's a question that becomes a whole different discussion. I think Dr. Jagatpal spoke on occlusion in one of the previous SADA lectures. But in essence, if the patient needs an implant occlusion or implant protected occlusion is something that is critical for the long-term success of that implant. And at the same time, we shouldn't only be replacing an implant or replacing a tooth rather at 2.2, 2.6 is missing as well. So this is catastrophic. Now we got to ask the patient to go back to the referral clinician and either restart the whole aligner process, which comes with its own permutations, time, cost, professional integrity. And at the same time, do we refer this patient to an orthodontist, and the patient who was sold on aligner therapy, the clear invisible braces, now would need fixed orthodontics. And certainly the patient does need fixed orthodontics to correct this type of situation. I think at the same time, it's important to mention, when we did speak to the primary clinician of this patient, the initial complaint that the patient had was crowding or malalignment of the lower anteriors, and aligner therapy corrected that, and it was a side issue or a secondary issue that the patient ended up wanting the denture replaced with an implant. It still doesn't forgive or explain the situation, because in essence, treatment planning should be all encompassing, regardless of whether there would be an implant to replace tooth number 2.2 or whether it was going to be a denture. Aesthetically and functionally, it needs to conform to certain size parameters and dimensions, which in this case it did not. So aligner therapy should not be only executed for implant work, even if there's a partial denture that's going to be done. It needs to be adhered to in that way. Endodontics, and I think the beauty about technology is that it also picks up the innocent mistakes or the innocent lies that we tell ourselves, or the not so innocent ones. And the periapical on the left was what the patient presented with, and the patient said that the good dentist broke a file in the tooth and advised her to seek help and have the file removed. And I looked at it, it was tooth number 2-1 with the broken instrument or a separated instrument, and we either needed to bypass, remove, so on and so forth. And on first attempt of placing another file in there, it just felt like hitting concrete. It didn't make sense. And after a few attempts, that's when a sectional CBCT was taken, and then we can see that actually 2 files were broken in the same tooth. So obviously the clinician didn't have access to a CBCT at that time, and the CBCT wasn't taken preoperatively. And I'm not saying that a CBCT should have been taken preoperatively for endodontic treatment on the 2-1, but in this case, a file went in, it broke, and the clinician went with another file, and that also broke. And obviously in the periapical X-ray, we only see 1 broken instrument. So CBCTs do help with diagnostics and subsequent treatment, because had we not had access to cone beam tomography in this case, we probably would have been sitting here still wondering how to solve this patient. I think no digital talk or presentation will be complete without implantology, and implant planning and digitization is probably one of those main pushing points that's forging digital dentistry forward. And one of those classical patients of unbound edentulous mandible, or partially edentulous mandible, and the patient needing premolar and molar on either side. And the scans were done, the records were taken, and everything was done according to what the textbook would want, and a surgical guide was fabricated and ready for surgery. Yes, the whole discussion on having a flapless, so whichever way we may go. However, surgical guide was done, and the surgeon, fortunately in this case, raised a flap, his preference. But what we picked up was that the surgical guide was actually, well, the pilot drill was completely buckled to the ridge. So here again, there is distortion that can be introduced on some level. There are issues that we need to be mindful of, because had we just went completely blind with the surgical guide and say, let's drill and place an implant fully guided, it is the most accurate way of placing an implant. And yes, it does show high success and high levels of accuracy, but without your checks and balances, which still form part of the analog world, you can run up in big, big trouble. So these are part of the clinical challenges that we do see. Do I see myself replacing the intraoral scanner or replacing Improgam with an intraoral scanner? I think not. I think they both fit into this beautiful little picture that we like to paint for ourselves in terms of how we're going to execute treatment plans. And there's certainly a need for both. Definitely, we can't eliminate one, and both have serious advantages that we need to accept and respect before we say that digital is the gold standard. Because by saying digital is the gold standard, what we are saying is anything that is not digital is substandard. And I think that's something that we need to think about quite carefully. And if I think about my old man and my father, and life lessons that you grow over the years, and he always says, just do the basics right. Do the basics right, and the bigger things will fall into place. And I took this periapical of a patient that came in part of a routine examination, and I was looking at that 1/6 composite restoration and looking at the marginal contour of that. And I thought to myself, how well have we mastered our fundamentals, and how well have I mastered the basics of dentistry to say that I'm moving into the digital domain and going to push forward with the ego of dentistry of having an intraoral scanner if we are still having direct restorations that look like that. I think before we say, let's take that step forward, we need to make sure that our baselines are done correctly. And I think this is a classical example of that. It's important that we adhere to this matrix bands, wooden wedges, sectional matrices, whichever we're using, but we need to get our basics done correctly before we start venturing forward, because we will not be able to pick up the problems if we scanning and then designing and we don't understand tooth anatomy, contours and shapes. How will we design a crown that would conform to biological health? So in conclusion, I definitely think it's not a question of if, but when to delve into digital. And I think most of us, if not all of us by now, should be working in the digital domain on some level, whether it's direct or partially or completely. I think it's critical that we are on that level in 2020. But it should be emphasized that further scientific validation on digital treatment is necessary to understand the impact of this promising technology for modifying well-established conventional protocols. The benefits are obvious. It's a reduced production costs, improved time efficiency, patients' perceptions of a modern treatment concept will also be met. So I think in conclusion, I'm still going to be on the fence and I'm not going to push for one over the other. But I think the most important thing is that we're just mindful of what we're doing, how we're doing, and what's the intention behind what we're doing. Yeah, so I just wanted to thank SADA and APSA for giving me this opportunity of speaking this evening. Yeah, I hope I was able to be of benefit to a greater audience. Thanks a lot.
Thank you, Dr. Haffajee. Your presentation has certainly raised a number of pertinent issues, and there is a series of questions that the participants have raised. So I'll hand over to Dr. Osman Lateef to take the Q&A.
Thank you, Dr. Haffajee. I think I would like to take this opportunity to ask you a question before opening it up to the delegates. In your opinion, what do you think of the term digital is better? Do you think that this is factual? Is it a fallacy? Where do you sit on this?
I think I touched on it a little bit in the lecture. Digital is better, but I think no two cases are the same. And again, for me to say that digital is better would basically be me sticking out my neck and saying that if I was doing analog on any other case, I'm giving that patient something that's less. So I think every patient needs to be treated on its merits. And if digital is safe and will give us the results predictably, then it certainly should be used. So yeah, I think that's a very politician-like answer to give, I guess.
Yes, no, it is, but thank you very much for that. For now, I am going to just look at some of the questions that the delegates have raised. One wanted to go and know in terms of the use of digital dentistry in a practice that is a medical aid practice, the affordability and feasibility with that.
I think it's always going to be a tough one, especially in our situation in this country. When you're looking at medical aid practices, I think overseas the group practice type of situation works well. So I think it's really based on an individual and how they perceive their practice model or their financial practice model to be. And I think it's really an individual thing. There's some individuals that run their practices as a hobby and not as an income generating tool. And others, it's their sole source of income. And whether they want to be investing that kind of money and their source of income when they still have probably a mortgage or vehicle finance, I think really individuals can work on that there. It's tough to comment on a blanket term on what would work for an individual. There was one comment that I did see, if I may go through it, was from an anonymous attendee. And he or she says, I run a very busy practice doing mostly conservative work and prevention in my practice. I am financially stable and sleep well at night. My patients find my fees affordable. I offer my patients the best that is available, that is affordable. And can the speaker advise if I should change to what is in vogue? My fear is that I will not sleep well, become financially unstable, and my fees will become unaffordable to the person in the street. Presently, I can survive for another 15 years as is. And I think that pretty much echoes the thoughts of many such practices. And certainly, I don't think there's anything wrong with that. I think the individual will be able to question himself on what he's offering as the best that's available. If he or she if you're taking a crown and bridge impression with an alginate, you obviously know you're not doing something that's better for the patient. Even though it may be affordable, you should be using a polyether or PVS. So I think as long as your fundamentals of material selection, material choice, and the way you executing treatment plans are done in a way that's based on evidence, and there is enough evidence to support the analog workflow in the right situation. And I think it becomes a situation of where it can become a situation where that if patients feel that they need digital, or if a case shows that it does need digital, then it can be referred beyond that. So I think there's nothing wrong with the individual doing what he's doing. Yeah.
And there is another question. Isn't the purpose of digital technology, example CBCT, to assist in arriving at a more improved ability to find and diagnose a disease state and treating a disease condition? So whilst making money may play a role, the most important role of the clinician's radiographs should guide them to doing what is indicated in improving their patients' overall health. Where do you see digital technology?
I think I see digital technology really fitting in a lot more with the way we execute. I think it's a personal thing. I like toys, I like gadgets. Most of us do. But I do see ourselves using digital workflows more and more efficiently. And I won't say it's going to become the mainstay, but I think since I've got access to an intraoral scanner of late, I've been using it a lot more than what I thought I would. And I think purely because it just allows communication efficiency in how we're going to do things. So yes, taking the radiographs and doing things in the right way. I think this type of conversation will go on for a long time as well. But I do see it as being the future, not as the independent future, but a strong part of the future. I think I see also Mark Bowes. He said the liner case is a problem of user skill and not digital workflow. 100%. I totally agree with that there. And the reason why I'm just commenting on Mark's comment is because it's something that I probably didn't emphasize enough. Aligner therapy does have its place. It does work in the right hands. I'm not an aligner therapy specialist. I don't do it. I'm not a fan with it. But I think whoever is doing it needs to know that digital does require input. And input means that you as a clinician need to have done a space analysis or a Kesling setup or a smile analysis of so on and so forth. So digital is not exclusive. Analog is required of some component, or the clinician is required to give his input at some point.
Then I practice in the location. I am very busy in practice, mostly working class patients. How would digitalization help me in my practice? Please help in my decision making.
Good. I think digitization can help in really any practice. Then individual doesn't speak about finances. So I think I'm going to go with the fact that it is available. But it can certainly help. And I think currently we're able to use digitization for everything from removable partial dentures going across to fixed. I think also whether the patient's in a location or not, humans have become a lot more informed in treatment, and using digital as part of that training tool or education tool forms a very big aspect of it as well. I think I've been using digital a lot for patient education, showing things that patients would have otherwise not seen. And I think that it puts a very different feel to the type of work that you're putting out when you're showing the patient a plaster model of their mouth versus an image of their mouth. And then in subsequent visits, when they come back to you and they see a 3D model, then it's always that wow thing. So it really does play a role in adding a better class or exude to your practice, but certainly from your own self as a clinician, I think anyone that has been able to deliver a fixed prosthesis that has been done digitally or with the CAD/CAM procedure versus an analog will certainly be a testimony to how good it feels. I think can't say it in the most academically correct way, because it's really an emotive thing as well, that just clicks into place. And yeah, I think that's about it. I think also digital has become really cool these days, where now we can do a lot more than just taking impressions. You're looking at TMJs, you're looking at excursive movements, you're looking at a lot more breathing, airway analysis. There's so many components to that. And regardless of where your practice is located, there's always going to be a patient that sleep apnea has become a huge thing as well. And these analyses do help patients, as long as, again, the clinicians are well versed in it.
Okay, thank you. And then just one more. When we're looking at digital versus analog, and we're actually looking at medical aids, when that plays a role, how do we then make the decision? Because most medical aids don't really cover extensive restorative work, and most people actually rely on their medical aid benefits to pay for treatment.
I'm going to stick my neck out there and say that I don't work with medical aids. So I really can't comment on that. And I think I've chosen not to work with medical aids because of the limitations that medical aids do offer. So I think I decided that seeing that I was going into practice quite early was that I wasn't going to base my practice on the medical aid model. And so I was able to offer treatment the way I saw fit and let patients decide how they want to manage their finances from there. I think the responsibility that we take on as clinicians is great, and it's an honorable responsibility, but to take on a patient's financial responsibility is also a bit more than what I would be able to hold onto my shoulders. So I think, yeah, individuals will be able to know how they want to do it. I don't know if that answers the question.
To a certain degree, yes. I think that's maybe a challenge that we actually have when we're looking at trying to introduce digital dentistry into the practice. Now, if we take that into the healthcare system, there's the move to going more cheaper and affordable servicing. Don't you think that these digital instruments would restrict practices from actually going digital? Or do you maybe think that there could be a role for having both?
I think it's such a nice topic. It's such a nice point that you make there, because I was actually chatting to someone about it recently, that digital is supposed to be a cost saver. You look at the cost of a little Emacs block and how much that costs and how much the laboratories are still charging us for the cost of the crown. And it's not really a cost saver. The laboratories are still charging us the same as what they were charging us when they were doing the analog technique. So I think they obviously have the argument of paying off their capital output or their investment in the equipment. So it's a fine balance that no one has 1.5 million rand laying around as disposable money to start doing crowns at 1,000 rand each. So at some point, we need to be able to draw that line. Yes, we want to do affordable dentistry and we want to be able to save patients costs, but I think we need to be able to stand up and say, look, but we also want to do what's best and we want to do what's right as well. And it's really an ethical or a moral type of decision, and it's not really a topic that I'm going to be passing judgment or passing a blanket rule on, but I think individuals will know that we can cover up or sugarcoat the truth only so far. When we have failures, we know we have failures. We know we have complications. And regardless of how we spin that story verbally, I think inside we know. So I think as an individual, we know where we want our practice models to be. And yes, it may not have to be as a first world practice model. I think there is certainly space within the South African context of running a good medical aid practice with corrected overheads and still running a busy practice, but being able to afford patients the best thing possible. I think there's also, with this, there's also, I don't know much about it, but there's options of leasing equipment and letting equipment. And I'm not going to go into all of that, but people know how these things work, and these things become options as well, dependent. I think another thing also is there's certain laboratories that have scanners, clinical scanners that they bring to individuals' practices to scan up cases. There's some laboratories that I heard of that will drop off a scanner at your practice as long as you send a certain number of units a month to them. Whether that's ethical, whether that's right, that's a whole different discussion. But I think people need to be aware of these things. I could have probably added that as challenge number 9 in terms of how biased we are in the way we execute treatment, and based on the element of bias that's put forward to us. Yeah, I think it's an interesting space that we're heading into.
Yes, no, it is. I think you already touched on what one of the delegates wanted to find out, your opinion on renting an intra scanner to assess the suitability, if the technology as well as compatibility of the user. So, you know, by the looks of it, some companies would most likely be offering that. And from what you said, there are some laboratories who are offering that, but that in itself comes with its own ethical challenges. Can you comment on in-practice milling such as CEREC versus lab mold restoration?
Personally, I'm against in-practice milling. I feel like, just my opinion, I think my skill lays in clinical work. I'm not here for designing and milling and staining and glazing and adjusting and doing contours. That's not where that's not where I fit myself into. I also look at I honestly don't know how people have been in practice for 30 years. I think about managing patients, managing staff, managing finances, managing overheads, managing patients that have paid and haven't paid, managing laboratories, reps, and to still think that I need to fit in my day and do the best job possible on chairside milling. I don't think I can do that. And I'd rather send that work out. I think some clinicians feel differently about it, but I think that's where I fit into that spectrum. Maybe if I change, then I'll come back here and say that I changed. But I think for now, I'm pretty happy in the space that I find myself in with regards to that.
Okay. And then just 2 more comments. One from someone in the audience. I worked at a medical aid practice, and using CEREC for our crown and bridge work has increased our income greatly. We split the bond between a few of us, and I think that it's possibly the reason it is working for us. Taking finances out of the picture, the work we are able to deliver is of far better quality. And I think that's sort of nice in a way that sometimes it's not always about the finances, it's about the quality that we're actually providing for the patient. And in that way, that serves as an incentive for the practice to actually grow.
Yeah, I think I saw that, and I like that because I think it's how we should be working together. Sometimes we're becoming a bit too competitive between one another, and whatever reason it may be. But I think we're able to do it together. We sharing the expenses, and it really becomes a fraction of the fee, and work becomes a lot more enjoyable. So I actually like that comment as well.
And then just a last comment from myself, just to say that if I just look at how innovations have actually changed the way we have seen things and we are doing things. For example, phone application, that particular phone application being Uber, it has actually revolutionized the way people not only work, but the way that we actually travel. I can safely say that digital dentistry is a disruptive innovation, where it has actually changed the way that we do good. We're now looking at different things to make things not just only cost benefit, but also for us to go and provide a better treatment and treatment options for our patients. Okay. On that note, thank you very much, Dr. Haffajee. And I would like to give the floor back to Professor Moipolai.
Thank you, Dr. Osman Nateeb and Dr. Haffajee. I think one of the pertinent issues that really you raised, Dr. Haffajee, is the fact that technology needs to support the clinical practice and not take over from clinical practice, because at the end of the day, our professional identity is as clinicians, and we can't devolve the clinical acumen to technology. But like Dr. Osman Latif said, the rapid innovation that is happening in technology, especially in oral health, has caused a disruption in how we practice dentistry. But fundamentally, it should not take away from our clinical diagnostic skill sets, because that is our professional identity. And on that note, I want to take this opportunity to thank all the participants. At one stage, we were close to 420 participants on the line, and it's a testament to the interest that this topic has within the profession. So please don't forget to do the evaluation at the end of the webinar. And also don't forget the upcoming webinars. On Thursday, we have a Henry Schein evening with Dr. Tara Makon. And next Tuesday, we have a SASPIO evening with Dr. Bamji. And on the 29th of September, it's another Henry Schein International evening with Dr. James Robson. So thank you very much and have a pleasant evening.
Thanks, Prof.
Thank you, everybody. Have a good evening. I'm going to end the webinar now.
Thank you, Marilise. Thank you, Norma. And thank you, APSA.
Good night.
Good night.